what happens is why saline OCT? Because there's a large percentage of population who are having renal dysfunction, and for them this becomes a real boon when you are doing complex bifurcation and even proximal vessels. Well, if you are used to the machine which we operate ourselves, there's a saline contrast, 2:1 contrast saline, 1:1 contrast, and the saline. So these features will help you to do what is called as saline OCT. So what are the challenges in doing the saline OCT? See, in our initial learning phase, RCA, we were able to tackle it very well because single vessel, not many big branches out there. So RCA was done very well. However, the left system was in trouble because, especially when you have a dominant circumflex, then to have the saline going into the LED and getting the images is going to be crucial. Second part is, if it's a diseased vessel, you get much better pictures because the resistance is there, and your saline goes in well, and you get good pictures. But once you stent these vessels, for example, you stent an RCA, the resistance is not much, and then the clearance is not that great, and then you have trouble. So this was all our initial experience, how it happens. So when we started doing saline OCT a few years back, as you can see, we had no idea how much contrast to take, what force to inject, and all those things. But then we were able to see the distal edges well, and in the middle panel you see, when it comes to see the stent, it was all contaminated with blood, and the proximal was totally contaminated, and we were not able to see any part of it. So we used to do multiple short segment runs when we started doing the saline OCT, and that was taking a lot of time. And similarly, even in the LED, sometimes part of the stent is visible, part of the stent is not visible, and then even the stent was visible, the studs were not seen in all the quadrants. And the worst part is, by the time you come to the proximal segment, the saline was depleted, and the proximal part of the stent was not seen. We were missing a lot of edge dissection in the proximal segments. So this is what was happening, and this is what was all the learning curve. So what we started doing initially was taking multiple runs, even after stenting. We used to do short runs, and then combination to combine all the things and to find out was very, very difficult. So why images were not clear? Because there was, foremost thing is inadequate vessel clearance due to low viscosity of the saline. Second was the delayed distal clearance and insufficient injection pressure. These were the two things we thought was important. And as the lens comes proximally, your saline is depleted. So by and far, if you're doing a long run, your proximal vessel is not seen, so you end up doing another sort of run on it. So what did we learn? Doing all these things, we now started understanding how to do our injections. So in the right coronary artery, pre-plasty, what we do is we take a 20 cc saline, hand injection, and it gives you very, very good pictures. And it's a 75 millimeter run. I'll come to that. And once it's stented, what we do is we take 30 cc saline, maybe in a 50 cc syringe, and then we give it, we do the study. And the most important thing is the pressure, the masculine pressure, what we call it as, very, very important to get this clearance of the blood and get good images. The left side is in a trouble. We are trying to modify it, and we are trying to learn more of these things, especially when you have a dominant circumflex and you want to image an LED. It's practically impossible to get good pictures because plus 50% of the saline goes into the circumflex. So there are modifications. For example, we put a mother and child guide. We use a guide extension, and we go into the LED, image that area of interest, not very long runs, just the area of interest. Well, putting a guide extension does not completely give that access to give all the saline into the vessel, but at least some majority of the saline goes into it, and you can do the studies. However, if there's a LED ostium or circumflex ostium disease, again, these things don't work, and you'll have to take contrast injection. So this is the algorithm. What we have done is RC is 20 cc syringe, 20 cc saline, works out very well. Even if it's super dominant vessel, it works very well. For selective LED and LCX engagement, 20 cc syringe with 20 cc saline, that is with your guide extension catheter. But if you want to do it non-selective, then you have to take a 50 cc syringe and 30 cc saline. Don't take the entire syringe, because 50 cc will not be able to generate any pressure, will not be able to inject. So that's what we'll be doing. Some centers are using power injector. We have done initially in a few cases, but this also is very tedious to do this. So it's more or less the same. For RC, you give it 4 mils per second at 400 psi, and for selective left, you do the same thing, 4 mils, or for the entire left coronary artery, 5 mils per second at 400 psi. So power injector also can be used. So what we learned was, if you know this machine well, the 75 millimeter run takes about 2.1 second, whereas 54 millimeter run takes about 3 seconds. Here, the 54 millimeter gives you a much clarity. However, you can't do that because you get depleted with the saline. So always do a 75 millimeter run. It's a shorter time. And what Zia was telling other day, that now the new machines have got 1 second pullback. So probably that, I think, we'll be able to do more of those cases with saline injection. So automatic mode and manual mode, you have to understand. Automatic mode takes 50 cc of clearance for the lens to realize to start moving proximally. So it needs 50 cc of clearance. So by the time, if you're injecting saline through an automatic mode, 50 cc is difficult to achieve. By the time, the lens will not move. By the time it starts moving, your saline is depleted. You end up missing the proximal segment. So what you do is you take a manual mode. So once you see the manual mode, all you need is 10 cc or 10% of clearance. Once you see the clearance, hit the button, the lens starts moving, and then you inject. So with saline, it is always manual pullback, and 75 millimeter is a preferred one, so you can get these pictures as good as possible. So this is how we improve now. This is how our images are looking like. We saw the distal segment. We see all the 3 layers. We know our landing zone. We know the diameters over there. Then we see the calcium, presence of calcium all through the thing, nodules. We see all those fibrotic lesions, and also we see the left main LCH. So our way of injection, way of technique is improved. So now more and more we are doing the saline OCT, and even the LED post-stenting. We can see the distal edge very well. We can see the distal dissections very well, which is a big concern. In this particular case, as you can see, the proximal part of the stent was dissected, and you can see the edge dissections very well, and also the left main. So we get good injections with saline, which is very good. However, in the left side, we are able to achieve only 60% good runs as of now with all the maneuvers, including the guide extensions and all that. 40% probably we have to cross over to contrast injections. So 3 things you have to remember when you do this kind of things in the OCT. One is optimal imaging, where you get all 3 layers, all 360-degree visualization of the vessel. Acceptable imaging is EEL more than 270 degrees, and unacceptable image is less than 270. When you have this unacceptable image and stuff like that, so probably you have to change yourself and get into contrast OCT. So last couple of slides, a small study which was there, which showed that the saline injection results in a smaller vessel diameter compared to contrast injection. So contrast gave a bigger diameters than saline. So this was studied. I was happy to borrow these slides from Dr. Ankush Gupta. So they did a contrast and a saline together. On the left-hand side, upper corner, you can see the distal reference vessel diameter was 2.42, and below the saline showed 2.33. Even the minimal stent area was larger in contrast than in saline. So similar things here also in this panel also, there was slightly increased size in contrast run versus saline run, but in some cases it didn't show the difference. And this is a matter of debate, and this is a matter of discussion whether it really is the truth. So stepwise approach, your kidney functions are creatinine is less than 1.2, so you can go with all these things what I explained to you. If the creatinine is more than 1.2, it's a heart failure, think about it. You're going to inject a lot of saline over there. If it's a single surviving vessel, I would not do all those things. I would straight away go to IVUS. And if your osteums are involved, again I say go for contrast injection. And if you want to do selective injections, you can do a guide liner based injection, guide extension catheter, or you can use power injectors too. So my conclusion would be heparinized saline is effective and safe substance to be used for OCT imaging injections instead of contrast medium in selected coronary arteries. However, this data should be supported by a randomized controlled trial. Thank you very much.
Very nice presentation. Do you combine saline with contrast 1:1, or always it's saline when you try saline?
No, when it's saline, it's only saline. I mean, this is typically, RCA is default for us. RCA default, whether creatinine is normal, abnormal, doesn't matter. RCA is default saline. For the left, depends on the creatinine and all those things, we take a call.
Very nice comment that if you're going for a less contrast one, I think just avoid OCT, go for IVUS if you've got a CKD patient.
And even in larger vessels, larger proximal vessels, bigger left means, and high creatinine, don't waste time and just do IVUS.
Yeah. The other tip is to be, you're going to have less clear imaging field than your heart is 60. And the reason is much of the blood mixes during systole. That doesn't happen on the right side because it's a low pressure system. On the left side is a high pressure system, and the heart, of course, is contorting. It's not just squeezing. So as it contorts during systole, blood gets pushed back from the branches and will almost look like a gating type appearance on your OCT pullback. That's very, very hard to overcome because of the viscosity issue. So one of the simple ways to do that is just give some beta blocker and drop the heart rate to around 60.
And one more thing that I would like to add, even if whenever you are going for a manual injection, be it contrast or saline, when you are injecting, keep your eye on the console, because each artery is different, size is different, your area of interest is different, and your pressure and volume will be different. If you are keeping your eye on the console when you are injecting contrast or saline, you will know how much pressure and volume is required to get the appropriately used, to be appropriately used.
That's a great point. Not only your eye, your ear, because you can actually hear the motor coming back.
Yes.
And you know that's when you need to clear the dye.
So many times we have seen that if with 20 cc saline, you can with 10 to 12 ml of saline, you can get with the RCA run, and for the left side, depending on your area of interest, even 12 to 15 or 16 to 18 ml of saline is more than enough to get this appropriately used run. We have recently concluded multi-center trial. Ajay Swami sir was part of it. We have compared 259 pairs of head-to-head comparison of contrast and saline, and we are seeing a good agreement in that also. But the only thing that is left is to standardize the injector, power injector for saline OCT.
So when we did the measurement comparisons, so the reason you get a measurement difference between saline and contrast is obviously the index of refraction of saline is different from contrast. And the calculated numbers that are theoretical are actually ended up being higher than the actual numbers, which is about 5% in diameter and 8% in area. But the good news is when we applied that to clinical use, it rarely changes your stent size. So if you use MLD max and you're doing EL and you have a 2.89 vessel, you're still going to use a 275. And if you're going to use a 3.6 EL, you're still going to use a 3.5. So it only changed your stent diameter in 8% of cases, but most importantly, it always made you downsize, which was safe. So the impact of this mismatch in size is not really clinically relevant.
In fact, in our last trial, we are finding that in some cases, you may get higher dimensions as compared to the contrast also. But I think that we have made that protocol. We start in this comparative trial. We are starting with the contrast, anti-G contrast, anti-G and saline. I think that makes a difference. And in few cases, in few reasonable good number of cases, again, that is not significant as far as PCI optimization is concerned. But we are getting sometimes we are getting larger dimensions also.
But the main reason for that is systole, right? Because you've done two runs that are simultaneously, but obviously you don't know if you caught the artery on pullback in systole versus diastole. And then what happens is the larger the artery, the bigger the delta, right? Yes. Because the larger artery can grow more in systole than in diastole. And so you'll see a greater standard deviation in vessels that are 3 millimeters.
But again, that was not significant enough to change the
Yeah,
dimension.
Ziad, one question. You said these new machines have got 1 second pullback.
Yeah,
You think on the left side with 1 second pullback, saline would be
it's much better.
much better.
It's, so the new OCT systems as well as an iteration of the Abbott system will lead to a faster pullback. And the faster pullback dramatically improves the utility of using saline. I mean, it's a 70% improvement.
In fact, Ultron 3, they are promoting it for even that it's good for saline OCT.
Fantastic. But I think we need to recognize that this is a way out where you don't want to use contrast, or you don't want to use too much of contrast, rather. And I think the best measurements and the best practices are still the use of contrast.
So
Because
is
that
it
gives
with injector or is it with hand?
So in my lab, we use the hand. There are some people who use injector, and yeah. So I use the hand for the reason that Ankush spoke of. That means I can increase the power of the injection and actually precisely deliver the volume and the power of injection that I need when I can hear the motor pullback. And that just comes with time. You just learn to use the pullback, but I think it's an individual thing. We tried to use the power injector, but we weren't able to hit the sweet spot.
So a few tips on that. You can only use MedRad, right? So if you use assist injector, the only way to do that is you must manipulate the system by getting a peripheral syringe. If you use a coronary syringe in an assist injector, it won't work. The reason is the index of refraction of contrast is within the stop limit of air. So it thinks the saline is air, so it won't let you inject. But if you put a peripheral syringe, the peripheral syringe drops the wavelength because in peripheral you use 50-50. So when you use a peripheral syringe, it will allow you to do a power injection on assist. Otherwise, you can only do power injection with MedRad.
Great point.